TB, Chapter 21, Caring for Clients with Lower Respiratory Disorders. Learning Objectives. Describe infectious and inflammatory disorders of the lower respiratory airway. Identify critical assessments needed for a client with an infectious disorder of the lower respiratory airway. Define disorders classified as obstructive pulmonary disease. Discuss strategies for preventing and managing occupational lung diseases. Describe the pathophysiology of pulmonary hypertension. List risk factors associated with the development of a pulmonary embolism. Discuss conditions that may lead to acute respiratory distress syndrome. Differentiate acute and chronic respiratory failure. Explain the difficulties associated with early diagnosis of lung cancer. Describe nursing assessments required for a client who experiences trauma to the chest. Explain the purpose of chest tubes after thoracic surgery. Describe preoperative and postoperative nursing management for clients undergoing thoracic care. Infectious and inflammatory disorders. Acute bronchitis. The pathophysiology and etiology is inflammation of the mucous membranes. The causes are Haemophilus influenza, Streptococcus pneumonia, and Mycoplasma pneumonia, fungal infections, and Aspergillus. Assessment findings include fever, chills, malaise, headache, dry, irritating, and non-productive cough, mucopurulent sputum. Medical management is bed rest, antipyretics, expectorants, antitussives, increased fluids, and antibiotics. Nursing management includes listening for lung sounds frequently, vital signs frequently, and coughing and deep breathing at least 1 to 2 hours. Pneumonia. Pneumonia is an inflammatory process affecting the bronchioles and alveoli. Pneumonia is an inflammatory process affecting the bronchioles and alveoli. Although it is usually associated with an acute infection, pneumonia can also result from radiation therapy, chemical ingestion or inhalation, or aspiration of foreign bodies or gastric contents. Pneumonia, when combined with influenza, ranks as the 8th leading cause of death in the U.S. Pathophysiology and etiology. There are 4 classifications for pneumonia: community-acquired pneumonia, healthcare-associated pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. Community-acquired pneumonia, called CAP, is the most common type of pneumonia. The client contracted the illness in the community setting or within 48 hours of admission to a healthcare facility. The typical causes are bacteria, atypical bacteria, viruses, and fungi. Bacteria, the most common causative bacterial organism is Streptococcus pneumonia. Others include Pneumocystis jirovecii, Jiroveci, Staphylococcus aureus, and Klebsiella pneumonia. This type of pneumonia is often referred to as typical pneumonias. S. pneumonia is the most common bacterial cause of pneumonia. It spreads from the upper respiratory tract to the bronchi and lobes of the lower respiratory tract. Mycobacterium tuberculosis also may cause pneumonia. The second type of community-acquired pneumonia is atypical bacteria, also causes pneumonia, referred to as atypical pneumonias. An example of this type includes Mycoplasma pneumonia. This type of pneumonia is sometimes called walking pneumonia because the symptoms tend to be less severe. It spreads from person to person through infected respiratory droplets. Another example includes Legionella pneumophila, the causative agent of Legionnaire's disease. Viruses also cause pneumonia, but more commonly in infants and children. However, the viruses that cause colds and influenza, Haemophilus influenza, in adults can lead to viral pneumonias. Fungi. Although not common, pneumonias caused by fungi can occur in immunocompromised clients or in clients with chronic health problems. Opportunistic fungal infections, those that take advantage of a host's compromised immune system, are the most usual causes of this type of pneumonia. Clients inhale aerosolized spores that are present because their habitat, soil or bird droppings, was disturbed. Once the lower respiratory tract is infected in immunocompromised individuals, it is very difficult to manage the infection as it spreads through the body. Healthcare-associated pneumonia, called HCAP, HCAP, is diagnosed in clients who generally reside in long-term care facilities or who are on dialysis in outpatient centers. HCAP may also include clients who were hospitalized within 90 days of being diagnosed with pneumonia. A common feature of HCAP is that the bacteria are more resistant to antibiotics, multi-drug resistance, or MDR. This feature makes treatment a challenge. Categories included with HCAPs include the following: immunocompromised clients who have underlying conditions that require immunosuppressant medications, such as clients with AIDS and long-term mechanically ventilated clients. Aspiration pneumonia can occur when a person inhales a foreign body, such as food or drink or gastric contents, during vomiting or regurgitation. Generally, pneumonia occurs with aspiration of infected material from the upper respiratory tract, usually bacterial. However, the nature of what is aspirated can impair normal lung defenses and lead to a pneumonia. Hospital-acquired pneumonia, abbreviated HAP, H-A-P, formerly referred to as nosocomial pneumonia, occurs in more than 48 hours after admission to a hospital. That is, it was not present when the client was admitted. Often these clients have MDR because of a history of chronic illness, or they are acutely ill, would admit it, and have prolonged hospitalizations. MDR, remember, is multi-drug resistance. The latter increases potential exposure to bacteria or other pathogens through invasive procedures and improper technique, such as with ineffective hand washing by healthcare providers. Hospital-acquired pneumonia can have a high mortality rate because of the virulent nature of the infection, the MDR involved, and the client's condition. Causative organisms include E. coli, Klebsiella pneumonia, Pseudomonas aeruginosa, which is Aeruginosa, and H. influenza, as well as methicillin-resistant staphylococcus, which is MRSA, MRSA. Ventilator-assisted pneumonia, VAP, is pneumonia that occurs 48 hours or more after endotracheal intubation. In reality, it is a subset of HAP because intubation and mechanical ventilation are the most common types of HAP in critically ill clients. There is overlap with the various classifications of pneumonia. In addition, other types of pneumonia can include the following. Radiation pneumonia results from damage to the normal lung mucosa during radiation therapy for breast or lung cancer. Chemical pneumonia results from ingestion of kerosene or inhalation of volatile hydrocarbons such as kerosene, gasoline, or other chemicals, which may occur in industrial settings. Hypoventilation of lung tissue over a prolonged period can occur when a client is bedridden and breathing with only part of the lungs. Bronchial secretions subsequently accumulate, which may lead to hypostatic pneumonia. Pneumonia is also characterized according to its presenting symptoms. Bronchopneumonia means that the infection is patchy, diffuse, and scattered throughout both lungs. Lobar pneumonia, L-O-B-A-R, means that the inflammation is confined to one or more lobes of the lung. Organisms that cause pneumonia reach the alveoli by inhalation of droplets, aspiration of organisms from the upper airway, or less commonly, seeding from the bloodstream. When organisms reach the alveoli, the inflammatory reaction is intense, producing an exudate that impairs gas exchange. Capillaries surrounding the alveoli become engorged and cause the alveoli to collapse, which is called atelectasis, further impairing gas exchange and interfering with ventilation. White blood cells move into the area to destroy the pathogens, filling the interstitial spaces. If untreated, consolidation occurs as the inflammation and exudate increase. Hypoxemia results from the inability of the lungs to oxygenate blood from the heart. Bronchitis, tracheitis, which is inflammation of the trachea, and spots of necrosis, which is death of tissue, in the lungs may follow. In atypical pneumonias, the exudate infiltrates the interstitial spaces rather than the alveoli directly. The pneumonia is more scattered, as described for bronchopneumonia. As the inflammatory process continues, it increasingly interferes with gas exchange between the bloodstream and lungs. Increased carbon dioxide in the blood stimulates the respiratory center, causing more rapid and shallow breathing. Without an interruption of any type of pneumonia, the client becomes increasingly ill. If the circulatory system cannot compensate for the burden of decreased gas exchange, the client is at risk for heart failure. Death from pneumonia is most common in older adults and those weakened by acute or chronic diseases or disorders, such as HIV, AIDS, cancer, and lung disease, or prolonged periods of inactivity. Complications of pneumonia include congestive heart failure, Empyema, which is collection of pus in the pleural cavity, Pleurisy, which is inflammation of the pleura, Septicemia, which is infective microorganisms in the blood, atelectasis, hypotension, and shock. In addition, septicemia may lead to a secondary focus of infection, such as endocarditis, inflammation of the endocardium in the heart, pericarditis, inflammation of the pericardium of the heart, and purulent arthritis. Otitis media, infection of the middle ear, bronchitis, or sinusitis also may complicate recovery, especially from atypical pneumonia. Older adults are at greater risk for pneumonia and may experience a higher acuity owing to concomitant health problems such as heart disease and diabetes. Vaccination against pneumococcal pneumonia is recommended for clients older than 50 years of age with a chronic or debilitating illness, those over 65 years, and residents in long-term care facilities. Current guidelines recommend a booster dose if the initial immunization was 5 or more years ago. Older adults should also be advised to receive an annual influenza immunization. Signs and symptoms. Symptoms vary for the different types of pneumonia. The onset of bacterial pneumonia is sudden. The client experiences fever, chills, a productive cough, and discomfort in the chest wall muscles from coughing. There is also general malaise. The sputum may be rust-colored. Breathing causes pain, thus the client tries to breathe as shallowly as possible. Viral pneumonia differs from bacterial pneumonia in that the results of blood cultures are sterile, sputum may be more copious, chills are less common, and pulse and respiratory rates are characteristically slow. The course of viral pneumonia usually is less severe than that of bacterial pneumonia. The mortality rate from viral pneumonia is low, but rises when bacterial pneumonia occurs as a secondary infection. Many clients with viral pneumonia are weak and ill for a longer period than those with successfully treated bacterial pneumonia. Diagnostic findings. Auscultation of the chest reveals wheezing, crackles, and decreased breath sounds. The nail beds, lips, and oral mucosa may be cyanotic or blue. Sputum culture and sensitivity studies can help to identify the infectious microorganism and effective antibiotics for treatment in cases of bacterial pneumonia. A chest x-ray shows areas of infiltrates and consolidation. A complete blood count discloses an elevated WBC count. Blood cultures also may be done to detect any microorganisms in the blood. A bronchoscopy may be done to obtain a sputum specimen for clients who have severe or chronic infection, or are immunocompromised or on mechanical ventilation. A CT scan may be done for clients with prolonged pneumonia to get a more definitive image of the lungs. Medical management involves prompt initiation of antibiotic therapy for bacterial pneumonia, hydration to thin secretions, supplemental oxygen to alleviate hypoxemia, bed rest, chest physical therapy, and postural drainage, which are techniques that involve manual pounding or clapping to loosen secretions, and positioning of the client to drain and remove secretions from specific areas of the lungs, bronchodilators, analgesics, antipyretics, and cough expectorants or suppressants, depending on the nature of the client's cough. If a client is hospitalized, treatment is more vigorous, depending on the potential or actual complications. Fluid and electrolyte replacement sometimes is necessary secondary to fever, dehydration, and inadequate nutrition. If the client experiences severe respiratory difficulty and thick, copious secretions, he or she may require intubation along with mechanical ventilation. Nursing management: the nurse auscultates lung sounds and monitors the client for signs of respiratory difficulty. He or she checks oxygenation status with pulse ox and monitors arterial blood gases. Assessments of cough and sputum production also are necessary. The nurse places the client in the semi-Fowler's position to aid breathing and increase the amount of air taken with each breath. Increased fluid intake is important to encourage because it helps to loosen secretions and replace fluids lost through fever and increased respiratory rate. The nurse monitors fluid intake and output, skin turgor, vital signs, and serum electrolytes, administering antipyretics as indicated and ordered. Identifying clients at risk for pneumonia provides a means to practice preventative nursing care. In addition, nurses encourage at-risk and older adults to receive vaccination against pneumococcal and influenza infections. Because the nursing care of clients with infectious lung disorders is similar regardless of the cause, the treatment is similar. Preventing pneumonia: promote coughing and expectorant of secretions if client experiences increased mucus production. Change position frequently if client is immobilized for any reason. Encourage deep breathing and coughing exercises at least every 2 hours. Administer chest physical therapy as indicated. Suction client if he or she cannot expectorate. Prevent aspiration in clients at risk. Prevent infections. Cleanse respiratory equipment on a routine basis. Promote frequent oral hygiene. Administer sedatives and opioids carefully to avoid respiratory depression. Encourage client to stop smoking and reduce alcohol intake. Pleurisy or pleuritis refers to an acute inflammation of the parietal and visceral pleura. During the acute phase, the pleura are inflamed, thick, and swollen, and an exudate forms from fibrin and lymph. Eventually, the pleura become rigid. During inspiration, the inflamed pleura rub together, causing severe, sharp pain. Pleurisy usually is a consequence of a primary condition, such as pneumonia or other pulmonary infections. The inflammatory process spreads from the lungs to the parietal pleura. Pleurisy also may develop with TB, lung cancer, cardiac and renal diseases, systemic infections, or pulmonary embolism. Assessment findings: respirations become shallow secondary to excruciating pain. Pleural fluid accumulates as the inflammatory process worsens. The pain decreases as the fluid increases because the fluid separates the pleura. The client develops a dry cough, fatigues easily, and experiences dyspnea. A friction rub, a coarse sound heard during inspiration and early expiration, is heard during auscultation early in the disease process. As fluid accumulates, the pleural friction rub disappears. Decreased ventilation may result in atelectasis, hypoxemia, and hypercapnia. Chest X-ray and chest CT scan shows changes in the affected area. Microscopic examination of sputum and a sputum culture may reveal pathogenic microorganisms. If a thoracentesis, removal of fluid from the chest, is performed, a pleural fluid specimen is sent to the laboratory for bacterial culture analysis. Occasionally, the physician may perform a pleural biopsy. Medical management: the underlying condition dictates the treatment. Analgesic and antipyretic drugs provide relief for pain and fever. A non-steroidal anti-inflammatory drug, an NSAID, such as Indocin, provides analgesia and promotes more effective coughing. Antibiotics will be prescribed for bacterial infections. Thoracentesis may be done for pleural effusion depending on the size of the effusion. Nursing management: the client has considerable pain with inspiration. Sneezing and coughing make the pain worse. The nurse instructs the client to take analgesic medications as prescribed. Heat or cold applications may provide some topical comfort. The nurse teaches the client to splint the chest wall by turning onto the affected side. The client can also splint the chest wall with his or her hands or a pillow when coughing. Providing emotional support is essential. The client is very anxious and needs reassurance. Pleural effusion. Pleural effusion is an abnormal collection of fluid between the visceral and parietal pleura. Under normal conditions, approximately 5 to 15 milliliters of fluid between the pleura prevent friction during pleural surface movement. Pleural effusion may be a complication of pneumonia, lung cancer, TB, pulmonary embolism, and CHF. The amount of accumulated fluid may be so large that the lung partially collapses on the affected side. As a consequence, pressure is placed on the heart and other organs of the mediastinum. Pleural effusion is an abnormal collection of fluid between the visceral and parietal pleura. Under normal conditions, approximately 5 to 15 milliliters of fluid between the pleura prevent friction during pleural surface movement. Pleural effusion may be a complication of pneumonia, lung cancer, TB, pulmonary embolism, and CHF. The amount of accumulated fluid may be so large that the lung partially collapses on the affected side. As a consequence, pressure is placed on the heart and other organs of the mediastinum. Assessment findings are fever, pain, and dyspnea are the most common. Chest percussion reveals dullness over the involved area. The examiner may note diminished or absent breath sounds over the involved area when auscultating the lungs and also may hear a friction rub. Chest, X-rays, ultrasound, and a CT scan will show fluid in the involved area. Thoracentesis is sometimes done to remove pleural fluid for analysis and examination for malignant cells. Medical management. The main goal of treatment is to eliminate the cause and relieve discomfort. Treatment includes antibiotics, analgesics, cardiotonic drugs to control CHF if it's present, thoracentesis to remove excess pleural fluid, insertion of a chest tube is to promote drainage over a longer period, and surgery for cancer when present. Nursing management. If thoracentesis is needed, the nurse prepares the client for this procedure. The client is usually frightened, thus the nurse must provide support. If a client has a chest tube, the nurse monitors the function of the drainage system and the amount and nature of the drainage. Lung abscess, empyema. The pathophysiology and etiology is localized pus formation. The causes are aspiration, bacterial pneumonia, or mechanical obstruction. Assessment findings include chills, fever, weight loss, chest pain, productive cough. Sputum is purulent or blood-streaked, and finger clubbing. Medical management includes postural drainage, antibiotics. Surgical management includes thoracentesis or thoracotomy. Nursing management includes antibiotics, chest postural drainage, high protein in the diet, and emotional support. In this diagram depicting postural drainage, this is the lung areas to be drained in the best postural drainage positions. As you can see, for lower and upper lobes, it is a different position in each picture. And the nurse can do this when caring for her patient, as well as a physical respiratory therapist. Influenza, also called the flu, is an acute respiratory disease of relatively short duration. The major strains of flu virus are A, B, and C. The strains are related yet distinct from one another. Each virus can mutate and produce variants within the given strain. The variants are called subtypes. The subtypes for type A influenza viruses are currently referred to as influenza A H1N1 and A H3N2. Influenza A and B generally cause the seasonal epidemics. Influenza C causes milder respiratory illness and not an epidemic. Viruses that cause influenza are transmitted through the respiratory tract. It is generally thought that it is spread via droplets when people talk, cough, and sneeze. People nearby inhale the drops or touch them on a surface or on their skin and then touch their mouth or nose. People are contagious for 1 day before they feel ill and up to 5 to 7 days after they get sick. The incubation period is between 1 and 4 days. Flu chiefly occurs in epidemics, although sporadic cases appear between them. Because the viruses change, Antibodies produced by those who have had one case of flu are not effective against new subtypes, and a different antibody must be produced annually or during major epidemics. Most clients recover. Fatalities usually are related to secondary bacterial complications, especially among pregnant women, older adults, or debilitated clients, and those with chronic conditions such as cardiac disease and emphysema. During a flu epidemic, the death rate from pneumonia and cardiovascular disease rise. According to the CDC in 2016, each year 5% to 20% of the population in the U.S. are diagnosed with influenza. More than 200,000 people are hospitalized, and depending on the severity of the epidemic, it is generally estimated that between 3,000 and 49,000 people die. Generally, death occurs in people who are over 65. Complications include tracheobronchitis, bacterial pneumonia, and cardiovascular disease. Staphylococcal pneumonia is the most serious complication. Signs and symptoms of flu that form the basis for a diagnosis. Onset would be sudden, abrupt onset of fever and chills, severe headache, muscle aches, progression to anorexia, weakness, apathy, malaise, respiratory symptoms, sneezing, sore throat, laryngitis, dry cough, nasal discharge, rhinitis, and conjunctival irritation. The duration of fever may persist for 3 days. Other symptoms usually continue for 7 to 10 days. Cough may persist longer. The period of contagion is 1 day before symptoms begin through 5 days after the onset of illness. Additional diagnostic studies such as chest x-rays and sputum analysis may be performed to rule out other diseases. Nursing management focuses on prevention. Annual flu vaccinations are recommended for healthcare providers and people at high risk for complications or for those exposed to many different people daily. Each year, a new vaccine is developed from 3 or 4 different virus strains that are predicted to be present in the coming flu season. Usually, the flu vaccine is trivalent, protecting against an influenza A, H1N1, another influenza A, H3N2, and an influenza B strain. If it is quadrivalent, another influenza B strain is added. The standard flu vaccine is made from inactivated influenza vaccine and is administered intramuscularly. Another form of vaccine is called flu mist, which is a live, attenuated influenza vaccine administered intranasally. It is approved for healthy children aged 2 to 5 years who do not have a history of asthma and wheezing, and for healthy persons between the ages of 5 and 49 who are not pregnant. Flu mist is not recommended for the following groups: people with underlying medical conditions such as diabetes or renal dysfunction, people with known or suspected immunodeficiency diseases or those receiving immunosuppressive therapy, people with a history of Guillain-Barré syndrome, children or adolescents who regularly take aspirin, pregnant women, people with hypersensitivity to eggs, children less than 2 years of age, and adults 50 years of age and older. Pulmonary tuberculosis, also called TB, is a bacterial infectious disease primarily caused by M. tuberculosis. TB essentially affects the lungs, but it may affect the kidneys and other organs. TB continues to be a worldwide health problem. About 1/3 of the world's population has been infected by TB, although they do not necessarily have active disease. It is the second leading cause of death from a single infectious agent. The first is HIV infection. This is per World Health Organization in 2016. In the U.S., as in much of the world, new cases of TB are slowly declining. Asian countries have the largest number of new cases. The World Health Organization, committed to stopping TB throughout the world, had a Millennium Development Goal of reversing the spread of TB by 2015 and met that goal globally. This incidence of tuberculosis has dropped by 18% since 2000. The death rate dropped 47% between 2000 and 2014. The WHO now has a Sustainable Development Goal of ending the tuberculosis epidemic by 2030. Tubercle bacilli are gram-positive, rod-shaped, acid-fast, and aerobic. Although they can live in the dark for months as spores and particles of dried sputum, exposure to direct sunlight, heat, or UV light destroys them in a few hours. They are difficult to kill with ordinary disinfectants and are destroyed by pasteurization a process widely used in milk and milk products to prevent the spread of TB. TB is transmitted most commonly through the inhalation of droplets produced by coughing, sneezing, and spitting from a person with active disease. Brief contact usually does not result in infection. In contrast to the number of people who have been infected with tubercle bacilli, only a small proportion ever becomes ill. Many factors predispose a client to the development of TB, including inadequate health care, malnutrition, overcrowding, and poor housing. TB is classified as latent TB infection and active disease. In clients with latent TB, the bacteria are present, but their bodies prevent the bacteria from multiplying. These clients do not have symptoms, are not ill, and are not contagious. TB bacteria become active if able to multiply. These clients are sick and contagious. The classification of TB is based on the client's history, physical exam, skin test, chest x-ray, and microbiologic tests. The Center for Disease Control and Prevention, 2014, classifies TB in a systemic way to monitor the epidemiology and treatment. TB is characterized by stages of early infection or primary TB, latency, and potential for reoccurrence after the primary disease called secondary TB. The bacilli may remain dormant for many years and then reactivate, producing clinical symptoms of TB. Early infection, tubercle bacilli, when inhaled, pass through the bronchial system and implant on the bronchioles or alveoli. Initially, the host has no resistance to this infection. Phagocytes, neutrophils, and macrophages engulf the bacilli, which continue to multiply. The bacilli also spread through the lymphatic channels to the regional lymph nodes and subsequently to the circulating blood and distant organs. Eventually, the cellular immune response limits further multiplication and dissemination of the bacilli. Immune activation. When immune activation occurs, usually a full response occurs within 2 weeks. A characteristic tissue reaction results in formation of a granuloma referred to as the GON, G-H-O-N, tubercle, from epithelial cells merging with the macrophages. Lymphocytes surround the GON tubercle, of which the central portion undergoes necrosis. This caseous necrosis has a cheesy appearance and may liquefy and slough into the connecting bronchus, producing a cavity. It may also enter the tracheobronchial system, promoting airborne transmission of infectious particles. Healing of the primary lesion occurs through resolution, fibrosis, and calcification. The granulation tissue of the primary lesion becomes more fibrous and creates a scar around the tubercle. It is referred to as the GON complex and is visible on chest x-ray. Latent period. As the lesion heals, the infection enters a latent period that can persist for many years or even an entire lifetime without producing clinical symptoms. If the immune response has been inadequate, however, the affected person eventually will develop clinical disease. Clients at particular risk are those with HIV infection or diabetes and those on chemotherapy or long-term steroids. Only a small percentage of those infected with TB actually develop clinical symptoms. Active TB. Secondary TB usually involves reactivation of the initial infection. The person already has had an immune response, and thus the lesions that form tend to remain in the lungs. The course of this phase usually is as follows. Acute local inflammation and necrosis occur. Infected lung tissue become ulcerated. Tubercles cluster together and become surrounded by inflammation. Exudate fills the surrounding alveoli. The client develops bronchopneumonia. TB tissue becomes caseous and ulcerates into the bronchus. Cavities form. Ulcerations heal with scar tissue left around cavities. Pleura thicken and retract. The course of TB becomes a cyclical one of inflammation, bronchopneumonia, ulceration, cavitation, and scarring. The TB generally spreads throughout the lung fields and into the rest of the respiratory structures, as well to other organs through the lymph system. A client may experience periods of exacerbation followed by remissions. Signs and symptoms. The onset of TB is insidious and early symptoms vary. An infected person may be asymptomatic until the disease is advanced. As symptoms develop, they are often vague and can be overlooked, particularly because they are systemic. Fatigue, anorexia, weight loss, and a slight non-protective cough are all symptoms attributable to overwork, excessive smoking, or poor eating habits. They also, however, are early symptoms of TB. Low-grade fever, particularly in the late afternoon, and night sweats are common as the disease progresses. The cough typically becomes productive of mucopurulent and blood-streaked sputum. Marked weakness, wasting, hemoptysis, which is expectoration of blood or bloody sputum, and dyspnea are characteristics of later stages. Chest pain may result from spread of the infection to the pleura. Diagnostic findings chiefly consist of the Manitou tuberculin skin test, called TST, a chest x-ray, a CT scan, MRI, and analysis of sputum and other body fluids. The Manitou test determines if a client has been infected with M. tuberculosis. A positive TST results in evidence that a TB infection has existed at some time somewhere in the body, but does not necessarily indicate active disease. The chief value of TSTs lie in case findings. All long-term care facilities are required to test each resident on admission for TB. The QuantiFERON TB was approved in 2005 for testing for TB. Another IGRA is called the T-Spot TB. Similar to the TST, it measures a client's immune reactivity to M. tuberculosis. Results are available in less than 24 hours. Unlike the TST, the results are not impacted by previous vaccination with bacillus, BCG, a vaccine for TB used in many countries, but not in the United States. With the TST, clients will have a false positive result if they have had BCG, but with IGRA tests, the results are not affected. The IGRA is conducted by obtaining a small blood sample that is mixed with antigens and incubated for 16 to 24 hours. Results are presented as positive, M. tuberculosis infection is likely, negative, M. tuberculosis infection is unlikely, indeterminate, test did not provide useful information, either repeat the test, give the TST, or do nothing. This is per CDC in 2014. The IGRA may be used in all situations in which the TST is used. As with the TST, the IGRA only indicates that a person has been infected with TB. It does not indicate anything about active disease or progression of disease. A chest x-ray may be done, particularly if there is a positive TST or IGRA. It may demonstrate white spots in the lungs indicating walled-off TB bacteria or lung changes related to active disease. Microscopic examination of sputum and other body fluids identifies the bacilli and is ordered when TB is suspected, especially during and after a course of drug therapy for TB and after surgical removal of a diseased lobe of the lung. The client is instructed to cough deeply so that the specimen does not consist mainly of saliva. Most clients found that it's easier to raise sputum when they first awaken. It may be necessary to collect specimens on several consecutive days. Gastric lavage, A 17-year-old's mother has been recently diagnosed with pulmonary tuberculosis. The nurse would expect the physician to order which of the following tests initially: A, the Mantoux test, B, chest x-ray, C, sputum culture, or D, gram stain of the sputum. Your answer should be A, the Mantoux test. A Mantoux test may be read in 3 days and will reveal whether the tubercle bacillus has entered the client's body. Obstructive pulmonary diseases. Bronchiectasis is one. Obstructive pulmonary disease describes conditions in which expiratory airflow is limited. Chronic obstructive pulmonary disease is an umbrella term for chronic lung diseases that have limited airflow in and out of the lungs. Symptoms of COPD include chronic cough and expectoration, dyspnea, shortness of breath, wheezing, and impaired expiratory airflow. Bronchiectasis, atelectasis, chronic bronchitis, and emphysema, although not categorized as COPD, involve chronic impairment of airflow. Asthma also is an obstructive disorder that is more episodic and usually more acute than COPD, secondary to narrowed airways because of bronchospasm, inflammation, and increased airway secretions. Sleep apnea syndrome can also have obstructive causes. Cystic fibrosis has obstructive characteristics that is included as well. Bronchiectasis is characterized by chronic infection and irreversible dilation of the bronchi and bronchioles as a result of destruction of muscle and elastic connective tissue. Causes include bronchial obstruction by tumor or foreign body, injury to the airway, congenital abnormalities, genetic disorders, exposure to toxic gases, and chronic pulmonary infections. When clearance of the airway is impeded, an infection can develop in the walls of the bronchus or bronchioles. The structure of the wall tissue subsequently changes, resulting in formation of saccular dilations, which collect purulent material. Airway clearance is further impaired, and the purulent material remains, causing more dilation, structural damage, and more infection. Assessment findings. Clients with bronchiectasis experience a chronic cough with expectoration of copious amounts of purulent sputum and possible hemoptysis. The coughing worsens when the client changes position. The amount of sputum produced during a coughing episode varies with the stage of the disease, but it can be several ounces. In addition to a chronic cough, clients experience fatigue, weight loss, anorexia, and dyspnea. The client's fingers may be clubbed secondary to respiratory insufficiency. Clients have repeated pulmonary infections. CT scans, which show bronchial dilation, provide an early and definitive diagnosis and differentiate bronchiectasis from bronchitis. Chest x-ray and bronchoscopy may be done also to demonstrate the increased size of the bronchioles, possible areas of atelectasis, and changes in the pulmonary tissue. Sputum culture and sensitivity tests identify causative microorganisms and effective antibiotics to control the infection. Pulmonary function studies also may be done. Medical management includes drainage of purulent material from the bronchi, antibiotics, bronchodilators, and mucolytics to improve breathing and help raise secretions, humidification to loosen secretions, bronchoscopy to remove purulent sputum, and surgical removal, rarely done if bronchiectasis is confined to a small area. Treatment is aimed at preventing complications such as respiratory failure and atelectasis. Nursing management focuses on instructing the client in postural drainage techniques, which helps client mobilize and expectorate secretions. The client remains in each position for these techniques for 10 to 15 minutes. These are shown in TIMBY on page 333. Chest percussion and vibration may be performed during this time. When complete, the client coughs and expectorates the secretions. This procedure may be repeated. The nurse provides oral hygiene after each treatment. Atelectasis. Clients with obstructive lung disease are at greater risk for developing atelectasis, the collapse of alveoli. Atelectasis may involve a small portion of the lung or an entire lobe. When alveoli collapse, they cannot perform their function of gas exchange. Atelectasis occurs secondary to aspiration of food or vomit, a mucus plug, fluid or air in the thoracic cavity, compression on tissues by tumors, an enlarged heart, and an aneurysm or enlarged lymph nodes in the chest. Ill clients may experience atelectasis when on prolonged bed rest, when unable to breathe deeply or cough and raise secretions, or both. The amount of involved lung tissue determines the extent of the symptoms. Small areas of atelectasis may cause few symptoms. With larger areas, cyanosis, fever, pain, dyspnea, increased pulse and respiratory rates, and increased pulmonary secretions may be seen. Although crackling may be auscultated over the affected areas, usually breath sounds are absent. A chest x-ray reveals dense shadows indicating collapsed lung tissue. Sometimes the x-ray results are inconclusive. CT scans demonstrate lung inflation and volumes, and if there's a tumor or other cause of obstruction. ABG and pulse ox results may be abnormal. A bronchoscopy may be done to determine if there is an obstructive cause, such as tumor or a foreign body. Treatment includes improving ventilation, suctioning, chest percussion, and deep breathing and coughing to raise secretions. Bronchodilators and humidification assist in loosening and removing secretions. Oxygen is administered for dyspnea. Removal of the cause of atelectasis helps to correct the condition. Nursing care focuses on preventing atelectasis, especially when the client is at risk because of failure to aerate the lungs properly. Postoperative deep breathing and coughing can prevent it. If atelectasis occurs, the nurse encourages the client to take deep breaths and cough at frequent intervals and instructs the client in use of an incentive spirometer. Medical management of obstructive pulmonary disease includes improving ventilation, suctioning, chest percussion, and deep breathing and coughing to raise secretions. Bronchodilators and humidification assist in loosening and removing secretions. Oxygen is given for dyspnea. Removal of the cause of atelectasis helps to correct the condition. Nursing management. Nursing care focuses on preventing atelectasis, especially when the client is at risk because of failure to aerate the lungs properly. Postoperatively, deep breathing and coughing can prevent atelectasis. If atelectasis occurs, the nurse encourages the client to take deep breaths and cough at frequent intervals and instructs the client in use of an incentive spirometer. Chronic bronchitis is a prolonged or extended inflammation of the bronchi, accompanied by a chronic cough and excessive production of mucus for at least 3 months each year for 2 consecutive years. This serious health problem develops gradually and may go untreated for many years until the disease is well established. Chronic bronchitis is characterized by hypersecretion of mucus and recurrent or chronic respiratory tract infections. As the infection progresses, the ability of the cilia that line the airway to propel secretions upward becomes significantly altered. Secretions remain in the lungs and form plugs in the smaller bronchi. These plugs become areas for bacterial growth and chronic infection, which increases mucus secretion and eventually causes areas of focal tissue death. Airway obstruction results from bronchial inflammation. Multiple factors are associated with chronic bronchitis. Its development may be insidious or follow a long history of bronchial asthma or an acute respiratory tract infection, such as influenza or pneumonia. Air pollution and smoking are significant factors. Chronic bronchitis may develop at any age, but it appears most commonly in middle age after years of untreated low-grade bronchitis. Diagnosis is based on evaluation of the duration of symptoms, determination of how the disease process began, and history of assessment findings. The earliest symptom is a chronic cough, production of thick white mucus, especially when rinsing or rising in the morning and in the evening. Bronchospasm may occur during severe bouts of coughing. Acute respiratory infections are frequent during the winter months and may persist for at least several weeks. As the disease progresses, the sputum may become yellow, purulent, copious, and blood-streaked after paroxysms of coughing. Expiration is prolonged secondary to obstructed air passages, cyanosis secondary to hypoxemia, especially after severe coughing. Dyspnea begins with exertion but progresses to occurring with minimal activity and later occurs at rest. Right-sided heart failure results from tachycardia in response to hypoxemia, which causes edema in the extremities. Diagnostic. Initially, results of the physical exam, chest x-ray, and pulmonary function tests may be normal. As the disease progresses, these findings become increasingly abnormal. Chest x-ray shows signs of fluid overload and consolidation in the lungs. As right-sided failure develops, the heart enlarges. Pulmonary function tests result in demonstrating decreased vital capacity and forced expiratory volume and increased residual volume and total lung capacity. Diagnostic studies such as bronchoscopy, microscopic examination of the sputum for malignant cells, and lung scan may be necessary to rule out cancer, bronchiectasis, TB, or other diseases in which cough is a predominant feature. Treatment goals are to prevent recurrent irritation of the bronchial mucosa by infection or chemical agents, maintaining the function of the bronchioles, and assist in the removal of secretions. Treatment includes smoking cessation, bronchodilators to reduce airway obstruction and bronchospasm, increased fluid intake, maintenance of a well-balanced diet, postural drainage to remove bronchial secretions, steroid therapy if other treatment is ineffective, and change in occupation if work involves exposure to dust and chemical irritants, filtration of incoming air to reduce sputum production and cough, and antibiotic therapy. Nursing management focuses on educating clients and managing their disease. The nurse helps clients identify ways to eliminate environmental irritants. Such measures include smoking cessation, occupational counseling, monitoring air quality and pollution levels, and avoiding cold air and wind exposure that can cause bronchospasm. Preventing infection is another important aspect of care. The nurse instructs clients to avoid others with respiratory tract infections and to receive pneumonia and flu immunizations. The nurse also teaches the client to monitor sputum for signs of infection and demonstrates the proper use of aerosolized bronchodilators and corticosteroids. Metered dose inhalers, MDIs, are pressurized devices that contain an aerosolized powder of specific medications. When the client pushes on the pressurized canister, an exact amount of medication is delivered via inhalation. Clients need instructions regarding the use of an MDI. It may be difficult for clients to coordinate the equipment and the need to inhale forcibly as the medication is released. For that reason, spacers, which are holding chambers, are added to hold the medication, allowing the client to inhale slowly and deeply and with more control to receive the full dose of the inhaled medication. There are other types of inhalers specific to particular medications. Each requires thorough client instruction. The nurse instructs the client in postural drainage techniques and measures to improve overall health, such as eating a well-balanced diet, getting plenty of rest, and engaging in moderate aerobic activity. For clients with lung disease, dyspnea, not heart rate, should determine the amount of aerobic activity. In other words, clients should exercise at the pace and for the length of time they can tolerate without dyspnea. Refer to nursing management of emphysema for nursing diagnoses and additional interventions. Emphysema is a chronic disease characterized by abnormal distension of the alveoli. The alveolar walls and capillary beds also show marked destruction. This process of destruction occurs over a long period. By the time of diagnosis, damage to the lungs usually is permanent. Emphysema is a common cause of disability and the most common obstructive lung disorder. In emphysema, the alveoli lose elasticity, trapping air that the client normally would expire. On microscopic examination, the alveolar walls are broken down, forming one large sac instead of multiple small air spaces. The capillary beds previously located within the alveolar walls are destroyed, and fibrous scarring replaces much of the tissue. Formation of fibrous tissue and destruction of the alveoli prevent the proper exchange of oxygen and CO2 during respiration. As the disease progresses, large air sacs called bulla and blebs may be seen over the lung surface. These sacs can rupture, allowing air to enter the thorax, called pneumothorax, with each respiration. In this case, emergency thoracentesis is performed to remove the air from the thoracic cavity. A chest tube may be inserted to keep additional air from entering. Recurrent episodes of pneumothorax may require surgery to correct the problem. Signs and symptoms. Shortness of breath with minimal activity is called exertional dyspnea, and often is the first symptom of emphysema. As the disease worsens, breathlessness occurs even at rest. A chronic cough invariably is present and productive of mucopurulent sputum. Inspiration is difficult because of the rigid chest cage, and the chest is characteristically barrel-shaped. The client uses the accessory muscles of respiration, muscles in the jaw and neck, and intercostal muscles to maintain normal ventilation. Expiration is prolonged, difficult, and often accompanied by wheezing. In advanced emphysema, respiratory function is markedly impaired. Clients with advanced emphysema characteristically appear drawn, anxious, and pale. They speak in short, jerky sentences. When sitting up, they often lean slightly forward and are markedly short of breath. The neck veins may distend during expiration. In advanced emphysema, memory loss, drowsiness, confusion, and loss of judgment may result from the markedly reduced oxygen that reaches the brain and the increased CO2 in the blood. If the disorder goes untreated, the CO2 content in the blood may reach toxic levels, resulting in lethargy, stupor, and eventually coma. This condition is called carbon dioxide narcosis. Lung auscultation reveals decreased breath sounds, wheezing, and crackles. Heart sounds are diminished or muffled. Visual inspection shows a barrel-chested person breathing through pursed lips and using the accessory muscles of respiration. Diagnostic findings include chest X-ray, fluoroscopy, and CT scanning that demonstrates hyperinflated lung fields. Results of pulmonary function studies show a decrease in overall function, including increased total lung capacity and residual volume and decreased vital capacity and forced expiratory volume. ABG analysis usually reveals hypoxemia and respiratory acidosis. Medical management. The goals of medical management include improving the client's quality of life, slowing the disease progression, and treating the obstructed airways. Treatment includes the following: bronchodilators to dilate the airways by decreasing edema and spasms and improving gas exchange. Aerosol therapy with nebulized aerosols for deep inhalation of bronchodilators and mucolytics in the tracheobronchial tree. Inhaled corticosteroid drugs and oral corticosteroids on a limited basis to assist with bronchodilation and removal of secretions. Supplemental oxygen may be prescribed. Antibiotics. Physical therapy to increase ventilation. Deep breathing, coughing, chest percussion, vibration, and postural drainage. If the prescribed regimen does not help the client, progressive loss of sleep, appetite, weight, and physical strength is likely. As the disease progresses, the client may need to curtail physical activities. Nursing management. Clients with emphysema may require supplemental oxygen. It's important to monitor oxygen levels as well as partial pressure of carbon dioxide levels because some clients with emphysema tend to have chronic hypercapnia, which is elevated PaCO2. For this group, when supplemental oxygen is given, the hemoglobin is saturated with oxygen and unable to carry CO2. This results in increased hypercapnia. The safest method of oxygen administration is by nasal catheter or cannula, with the oxygen flow rate set at no more than 2 to 3 liters per minute. If the client's color improves, but his or her level of consciousness decreases, the nurse discontinues oxygen administration and notifies the physician. The client may be approaching a state of respiratory arrest. Therapeutic breathing exercises effectively use the diaphragm through diaphragmatic breathing, thus relieving the compensatory burden on the muscles of the upper thorax. The nurse teaches the client to let the abdomen rise when taking a deep breath and to contract the abdominal muscles when exhaling. Clients can feel the correct way to do this by placing one hand on the chest and the other on the abdomen. During abdominal breathing, the chest should remain quiet and the abdomen should rise and fall with each breath. Other exercises include blowing out candles at various distances and blowing a small object such as a pencil or piece of chalk along a tabletop. The nurse encourages the client to exhale more completely by taking a deep breath and then bending the body forward at the waist while exhaling as fully as possible. Pursed lip breathing is breathing with the lips pursed or puckered on expiration, helps to control the respiratory rate and depth, and slows expiration. This maneuver may decrease dyspnea and in turn reduce the anxiety that often is associated with breathing difficulties. In addition, client education is aimed at helping clients adjust to their current level of disability and to the potential for increased disability in the future. The primary goal is to prevent or delay the progression of the emphysema. Clients who are motivated will profit more from available treatments and make the best use of their remaining pulmonary function. Client and family teaching following a treatment regimen for emphysema. The nurse teaches the client strategies to slow the disease progression. Success of treatment depends on the strict adherence to the treatment regimen. Take medication exactly as prescribed. Observe the time intervals between medications. Do not skip doses or take more than what is prescribed. Maintain close medical supervision. Contact the physician if adverse drug effects occur, drugs fail to relieve symptoms, new symptoms appear, symptoms become more severe, or signs or symptoms of respiratory infection develop. Drink extra fluids as indicated unless fluids are restricted. Avoid respiratory irritants in people with respiratory infections. Eat a well-balanced diet. Perform breathing exercises as prescribed. Take frequent rests during the day. Space activities to prevent fatigue and shortness of breath. Avoid dry, heated areas that can aggravate symptoms. Humidify inspired air during the winter months. Asthma is a chronic but usually reversible obstructive disease of the lower airway. Inflammation of the airway and hyperresponsiveness of the airway to internal or external stimuli characterize asthma. The incidence of asthma is increasing, particularly in children and adolescents. Asthma affects about 25 million people in the United States. This comes from the National Heart, Lung, and Blood Institute in 2014. Asthma may be fatal, but for most people it causes disruptions in school and work attendance and affects choices in careers and activities. The chronic inflammation associated with asthma is related to airway hyperresponsiveness in response to a trigger, an allergen or irritant. Common allergens include pollens, dust, mold, spores, and animal dander. Irritants in the air, such as cigarette smoke or other types of smoke, strong fumes, vapors or odors, and chemicals can cause an asthmatic response in sensitive individuals. Respiratory infections such as influenza, colds, and sinus infections can also cause asthmatic symptoms. Other causes of asthma include exercise, weather changes, emotional upsets, and medication sensitivity. Asthma results from increasing airway obstruction caused by bronchospasm and bronchoconstriction, inflammation and edema of the lining of the bronchi and bronchioles, and production of thick mucus that can plug the airway. The airway in people with asthma are hyperreactive in response to stimuli. Asthma causes the immunoglobulin E, IgE, inflammatory response. These antibodies attach to mast cells within the lungs. Re-exposure to the antigen causes the antigen to attach to the antibody, releasing mast cells, which releases histamine. The manifestations of asthma become evident as this occurs. Because alveoli cannot expel air, they hyperinflate and trap air in the lungs. The client breathes faster, blowing off excess CO2. Although the client tries to force the air out, the narrowed airway makes it difficult. Wheezing usually is audible with expiration, resulting from air being forced out of narrowed airways. Other pathophysiological changes include interference with gas exchange, poor perfusion, possible atelectasis, and respiratory failure if inadequately treated. Asthma may develop at any age. There appears to be a significant relationship between bronchiolitis, which is inflammation of the bronchioles in the first year of life, and development of asthma in early childhood. Asthma may be limited to occasional attacks, with the client symptom-free between attacks. Signs and symptoms include shortness of breath, wheezing and coughing, and the production of thick, tenacious sputum. Duration of acute episodes vary. It may be brief, less than a day, or extended, lasting for several weeks. Most clients are aware of the wheezing and report it as one of their symptoms. Every breath becomes an effort. During an acute episode, the work of breathing greatly increases, and the client may suffer from a sensation of suffocation. The client frequently assumes a classic sitting position with the body leaning slightly forward and the arms at shoulder height. This position facilitates chest expansion and more effective excursions of the diaphragm. Because life depends on the power to breathe, fear and anxiety often accompany and also intensify the symptoms. Marked prolongation of the expiratory phase of respiration accompanies the effort to move trapped air. Coughing starts with the onset of the attack, but it is ineffective in the early stage. Only as the attack begins to subside can the client expectorate large quantities of thick, stringy mucus. The skin usually is pale. During a severe attack, the nurse may observe cyanosis of the client's lips and nail beds. Perspiration typically is profuse during an acute attack. After spontaneous or drug-induced remission of the episode, examination of the lungs commonly shows normal findings. Sometimes an acute attack intensifies and progresses to status asthmaectasis, persistent state of asthma, which can be life-threatening. Diagnostic findings. Chest X-ray reveals expiratory and sometimes inspiratory wheezes and diminished breath sounds. Chest auscultation. Results of pulmonary function studies, especially of forced expiratory volume, may be abnormal, with total lung capacity and functional residual volume increased secondary to trapped air. The forced expiratory volume and forced vital capacity are decreased. During acute attacks, blood gases show hypoxemia. The PaCO2 level may be elevated if the asthma becomes worse, but usually the PaCO2 level is decreased because of the rapid respiratory rate. A normal PaCO2 level in the latter part of an asthma attack may indicate impending respiratory failure. Medical management. Symptomatic management is given at the time of the attack. Long-term care involves measures to treat as well as to prevent further attacks. An effort must be made to determine the cause. If the history and diagnostic tests indicate allergy as a causative factor, treatment includes avoidance of the allergen, desensitization, or antihistamine therapy. Oxygen usually is not necessary during an acute attack because most clients are actively hyperventilating. Oxygen may be necessary if cyanosis occurs. Pharmacological management may be classified as quick relief, rescue, and long-acting maintenance. Quick relief medications treat acute asthma symptoms such as wheezing and coughing and inability to breathe, whereas long-acting therapy is a daily regimen designed to prevent and control symptoms. Many medications are taken through MDIs. Humidification of inspired air is valuable because dehydration of the respiratory mucous membrane may lead to asthma attacks. Use of steam or cool vapor humidifiers has proved effective. Liquefaction of the secretions promotes more effective clearing of the airways and a rapid return to normal. Air conditioners may filter offending allergens as well as control temperature and humidity. Nursing management. During asthma attacks, clients are extremely anxious. The nurse provides reassurance that someone will remain with the client during the acute phase. The nurse administers oxygen if indicated and puts the client in a sitting position. Rest and adequate fluid intake are important. Increasing fluid intake makes secretions less tenacious and replaces the fluids lost through perspiration. The nurse keeps fluid within easy reach and encourages the clients to drink. The nurse checks the IV site frequently for signs of extravasation. This monitoring is especially important during an acute attack because restlessness can result in catheter dislodgement. The nurse observes for adverse drug effects, especially when the client is receiving epinephrine or other adrenergic agents, which may cause palpitations, nervousness, trembling, pallor, and insomnia. Clients with asthma must demonstrate understanding of the following. Asthma is a chronic inflammatory disease. Role of inflammation in bronchoconstriction, action and purpose of medicines, how to avoid triggers for asthma attacks, use of MDIs and other inhalers, use of peak flow monitoring, and when and how to obtain medical assistance. The nurse assesses the client's level of understanding of these topics and provides education as needed. The nurse determines whether the client has a peak flow meter and obtains one for the client if needed. The peak flow meter measures the highest airflow during forced expiration. The nurse instructs the client in using the peak flow meter to monitor the degree of asthma control. The client can use the peak flow meter to assess the effectiveness of medication or breathing status. The nurse tells the client to seek care if readings fall below baseline, teaches the correct use of inhalers, and also helps the client to identify triggering events such as dust, smoking, emotional upset, or exposure to irritants such as cleaning fluids or insecticides. The nurse teaches the client relaxation techniques and therapeutic breathing techniques as discussed previously in the section on the nursing management of emphysema. The nurse is instructing the client with asthma about the importance of measuring peak flow rates. Which of the following statements about the purpose of measuring peak flow rates is correct? They help him wean off his bronchodilator. They measure his response to bronchodilator therapy. They eliminate the need for blood test monitoring of the drug level. They determine when he may return to work. The correct answer is B. They measure his response to bronchodilator therapy. The rationale is that serial measurements of peak flow rate provide objective data of the therapeutics of a drug response. Cystic fibrosis is an medical management. Treatment depends on the stage of the disease and the extent of organ involvement. It aims at relieving the symptoms. A medication called KALYDECO, Kalydeco, a CFTR modulator, is given to clients 2 years and older with a specific gene mutation. This medication assists the defective protein to work at the cell surface so that sodium and fluid move into the airways to thin, thick mucus, making it easier to mobilize and cough up secretions. Another CFTR modulator is a combination of ivacaftor and lumacaftor called Orkambi, ORKAMBI, and is given when the child with a specific mutation turns 12 years of age. It moves the defective CFRT protein to the appropriate place on the cell membrane and increases the activity of the protein in order to thin the thick mucus. Respiratory treatment includes promoting the removal of the thick sputum through postural drainage, chest physical therapy with vigorous percussion and vibration, breathing exercises, hydration to help thin secretions, bronchodilator medications, nebulized mist treatments with saline or mucolytic medications, and prompt treatment of lung infections with antibiotics. Inhaled antibiotics such as tobramycin are being used successfully and have the benefit of decreasing systemic absorption. For some clients, ibuprofen, an anti-inflammatory, has been instrumental in slowing the rate at which lung function decreases. Other clients are benefiting from azithromycin, an antibiotic that preserves and improves lung function. When the digestive system is involved, clients take pancreatic enzyme replacements, such as pancrease, with all meals and snacks to aid with the absorption of protein, fat, and fat-soluble vitamins. Clients also take multivitamins and fat-soluble vitamin supplements and follow a high-protein, high-calorie diet. A liberal sodium intake is recommended to replace sodium lost through sweat. Clients with end-stage lung disease sometimes receive a lung transplant. In some cases, clients may receive a liver transplant as well. If successful, the transplants greatly extend the client's life. Other new treatments are in various stages of implementation and investigation. These include mucus-thinning drugs that reduce lung infections, NSAIDs, inhaled antibiotics, drugs to stimulate cells to secrete chloride and thin mucus, and gene therapy. The potential for clients with CF to live longer increases every year. Current research is focused on treating not only the symptoms, but also the causes of CF. Nursing management. Nursing care of clients with CF focuses on preventing complications and promoting a normal and healthy lifestyle. It is important that the client prevent respiratory infections by avoiding people with colds or flu-like symptoms, especially in the fall and winter months. Strict adherence to a vigorous pulmonary toilet, which is called pulmonary cleansing, is essential for the client with CF. Components include chest physical therapy, including postural drainage, percussion and vibration, 2 to 4 times a day, deep breathing and coughing exercises, nebulized treatments, and medications. New methods such as high-frequency chest wall oscillation through the use of an inflatable vest may better clear secretions from the lungs. Attached to an air pulse generator, the vest rapidly inflates and deflates to gently compress and release the chest wall, creating cough-like forces and increasing airflow in the lungs. In a 10 to 30 minute session, the airflow moves mucus towards larger airways where the client can clear them by coughing, huffing, or suctioning. Clients also need to recognize early signs and symptoms of infection, which include low-grade temps, increased mucus production, increased cough, and change in color of secretions from white to yellow or green. Clients must begin antibiotics as soon as infection occurs to prevent the infection from getting worse. Preventing or minimizing infection prevents or slows lung damage. Some clients are on prophylactic antibiotic therapy to decrease the occurrence of infections. This form of treatment is not common because of the threat of developing antibiotic-resistant infections, which can be deadly for clients with CF. Clients may be taught to administer IV antibiotics at home. For the client with CF who has significant GI involvement, the nurse must review the client's diet. Collaboration with dietitians can ensure that the client has a diet high in calories with appropriate amounts of carbs, fats, and proteins. It's essential for the client to take his or her pancreatic enzymes, creon or pancrease, which aid in the digestion of carbohydrates, fats, and proteins. The nurse reminds the client to take the pancreatic enzymes before or during all meals and snacks. Young adults with CF usually are very knowledgeable about their condition. Nurses must respect their knowledge and allow them to determine their schedule for treatment and procedures. The nurse provides support for clients' efforts in self-care, referring the client, as requested, to other healthcare professionals such as dietitians and respiratory and physical therapists. Occupational lung diseases. Exposure to organic and inorganic dusts and noxious gases over a long period can cause chronic lung disorders. Pneumoconiosis refers to a fibrous inflammation or chronic induration of the lungs after prolonged exposure to dust or gases. If specifically refers to diseases caused by the inhalation of silicosis, coal dust, black lung disease, Meniere's disease, or asbestosis, the resulting effect is referred to as restrictive lung disease, which means that the lungs have decreased volume and inability to expand completely. Although these conditions are not malignant, they may increase the client's risk for development of malignancies. The primary focus is prevention with frequent examination of those who work in areas of highly concentrated dust or gas. Laws require work areas to be safe in terms of dust control, ventilation, protective masks, hoods, industrial respirators, and other protection. Workers are encouraged to practice healthy behaviors such as quitting smoking. Dyspnea and cough are the most common symptoms of occupational lung diseases. Those exposed to coal dust may expectorate black-streaked sputum. The diagnosis is based on the history of exposure to dust or gases in the workplace. A chest X-ray may reveal fibrotic changes in the lungs. The results of pulmonary function tests usually are abnormal. Treatment typically is conservative because the disease is widespread rather than localized. Surgery seldom is of value. Infections, when they occur, are treated with antibiotics. Other treatment modalities include oxygen therapy if severe dyspnea is present, improved nutrition, and adequate rest. Many people with advanced disease are permanently disabled. Nursing management of clients with occupational lung diseases is basically the same for clients with emphysema. Many clients require a great deal of emotional support because these diseases may result in permanent disability at a relatively young age. Pulmonary circulatory disorders. Pulmonary hypertension, PH, refers to continuous high pressure in the pulmonary arteries and results from heart disease, lung disease, or both. It does not become clinically apparent until the client is quite ill. Diagnosis is difficult without invasive testing. Clients with pulmonary hypertension experience difficulty breathing and usually present as quite ill. Resistance to blood flow in the pulmonary circulation causes pulmonary hypertension. The pressure in the pulmonary arteries increases, which in turn increases the workload of the right ventricle. Normal pulmonary arterial pressure is approximately 25/10 millimeters mercury. In pulmonary hypertension, the pressure rises above 40/15 millimeters mercury and can be higher as the disease progresses. The World Health Organization has divided pulmonary hypertension into 5 categories based on the cause of the condition. Group 1 is pulmonary arterial hypertension. Group 2 is pulmonary hypertension. Group 3 is pulmonary hypertension. Group 4 is pulmonary hypertension. And Group 5 is pulmonary hypertension. However, each group is a little different. You can see this on page 345 in Chapter 21 in TB. Complex mechanisms cause PH, pulmonary hypertension. In early PH, the inner lining of the pulmonary arteries thickens and hypertrophies, followed by increased pressure in the pulmonary arteries and vascular bed. In late pulmonary arterial hypertension, alveolar destruction causes increased resistance and pressure in the pulmonary vascular bed. The increased resistance and pressure in the pulmonary vascular bed results in pulmonary hypertension. Consequently, strain is placed on the right ventricle, resulting in enlargement and possible failure. Hepatic congestion may also occur. The most common symptoms of PH are dyspnea on exertion at first and then at rest, as well as weakness. Additional symptoms are those of the underlying cardiac or respiratory disease: chest pain, fatigue, and weakness, orthopnea, difficulty breathing while lying flat, and dizziness. The client will show signs of right-sided heart failure, which include peripheral edema, ascites, distended neck veins, liver engorgement, crackles, and heart murmur. An EKG may show right ventricular hypertrophy or failure. Results of ABG analysis are abnormal. Cardiac cath demonstrates elevated pulmonary arterial pressures. The results of pulmonary function tests show an increased residual volume but a decreased forced expiratory volume. EKG may show various abnormalities such as left ventricular dysfunction and tricuspid valve insufficiency. A ventilation perfusion, VQ scan, or pulmonary angiography may be done to determine any defects in the pulmonary vessels, such as pulmonary embolism. Treatment of pulmonary hypertension includes the administration of vasodilators and anticoagulants and management of the underlying cardiac or respiratory disease. Oxygen therapy commonly is used to increase pulmonary arterial oxygenation. If right-sided heart failure is present, other treatments include medications such as digitalis or digoxin to improve cardiac function, rest, and diuretics. PH has a poor prognosis, therefore. Some affected clients are considered candidates for lung or heart-lung transplantation. Nursing management focuses on recognizing signs and symptoms of respiratory distress. The nurse can reduce the body's need for oxygen by preventing fatigue, assisting with ADLs, and administering oxygen when needed. Pulmonary embolism involves the obstruction of one of the pulmonary arteries or its branches. The blockage is the result of a thrombus, which is a blood clot, that forms in the venous system or right side of the heart. The majority of pulmonary emboli travel from the lower extremity veins, deep vein thrombosis, DVT, to the pulmonary arteries. The majority of pulmonary emboli travel from the lower extremity veins, called deep vein thrombosis, to the pulmonary arteries. For this reason, this condition is frequently referred to as venous thromboembolism, which involves both a DVT and a PE. An embolus is any foreign substance, such as a blood clot, air, or particle of fat, that travels in the venous blood flow to the lungs. The clot moves to and completely or partially occludes one of the pulmonary arteries, decreasing or totally obstructing blood flow. This causes gas exchange impairment and disrupts the VQ ratio. Eventually, infarction, necrosis, or death occurs in the lung tissue distal to the clot. Scar tissue later replaces the infarcted area. It is not unusual for clients to have multiple pulmonary emboli. Clots usually form in the deep veins of the lower extremities or pelvis and become the source for pulmonary emboli. Emboli may also arise from the endocardium of the right ventricle when that side of the heart is the site of an MI, or a myocardial infarction, or endocarditis. A fat embolus usually occurs after a fracture of a long bone, especially the femur. Other conditions that cause pulmonary emboli include recent surgery, prolonged bed rest, long journeys, trauma, postpartum state, heart valve malfunction, particularly in the elderly, dehydration, and debilitating diseases. Family history is a significant factor. A client with a family member who has had blood clots is more likely to have clots and pulmonary emboli. Clients who smoke, are overweight, and or take estrogen supplements are at higher risk for pulmonary emboli. 3 conditions referred to as Virchow's triad predispose a person to clot formation: venostasis, disruption of the vessel lining, and hypercoagulability. Assessment findings: when a small area of the lungs is involved, signs and symptoms usually are less severe and include pain, tachycardia, and dyspnea. The client may also have fever, cough, and blood-streaked sputum. Larger areas of involvement produce more pronounced signs and symptoms such as severe dyspnea, wheezing, severe pain, cyanosis, tachycardia, irregular heart rate, diaphoresis, restlessness, and shock. Sudden death may follow a massive pulmonary infarction when a large embolism occludes a main section of the pulmonary artery. Chest x-ray may show an area of atelectasis, and EKG rules out a cardiac disorder such as a MI, which produces some of the same symptoms. In addition, pulse ox and ABGs will be measured. A lung scan, a VQ scan, a CT scan, or pulmonary angiography is performed to detect the involved lung tissue. Ultrasound may also be done to confirm the presence of lower extremity DVT. A blood test called D-dimer assay is used to detect the presence of a protein when blood clots break down somewhere in the body. If positive, it is not definitive for a pulmonary embolus, but it does indicate that further tests are necessary. Treatment of a pulmonary embolism depends on the size of the area involved in the client's symptoms. PE often presents as an emergency. The treatment goal is to dissolve or lyse the clot in order to restore cardiopulmonary function. Pharmacological therapy includes the following. Anticoagulant therapy includes the use of intravenous heparin for the initial phase, or the use of newer anticoagulants, such as Arixtra, A-R-I-X-T-R-A. Maintenance therapy may overlap IV heparin and oral anticoagulants, such as warfarin, for several days. Newer anticoagulants, such as fondaparinux, may be given orally and do not have to be overlapped with IV anticoagulants. Thrombolytic therapy: these medications are used to dissolve clots. The most commonly used thrombolytic is tissue plasminogen activator, TPA, for massive pulmonary embolism. Thrombolytics can cause sudden and problematic bleeding and are only used for clients in life-threatening situations, such as those clients experiencing severe hypotension or hypoxemia. Other measures used to treat symptoms of pulmonary emboli include complete bed rest, oxygen, and analgesics. Surgical management may be done to remove a clot. PE can be removed using transvenous catheters or by surgical removal while the client is on cardiopulmonary bypass to support circulation. The insertion of an inferior vena cava filter serves as a screen to allow blood to flow but to prevent clots to pass. The primary purpose is to prevent recurrent episodes of pulmonary embolism. The best management of pulmonary emboli is through prevention of DVT. When determining the client's potential for DVT, it is important to note the client's ability to engage in activities such as leg exercises and ambulation. Clients on bed rest are encouraged to do active and/or passive leg exercises. Physicians may order clients to wear elastic compression stockings or use intermittent compression systems such as Venodyne. In addition, the nurse assesses the clients for signs of localized calf tenderness, swelling, increased warmth, or prominence of superficial veins in one or both extremities and history of DVT, all of which may indicate the presence of a DVT. Vascular changes of aging and chronic vascular diseases cause alterations in arterial and venous lumen, increasing the risk of DVT. The nurse should assess the older client's history of cardiovascular disease, level of activity, hydration status, and constricting clothing such as tight-fitting hose or socks. Pulmonary embolism almost occurs suddenly, and death can follow within 1 hour for a massive PE. Early recognition of this problem is essential for stabilizing cardiopulmonary function. The nurse starts an IV infusion as soon as possible to establish a patent vein before shock becomes profound. He or she administers vasopressors such as dopamine or dobutamine as ordered to treat hypotension. The nurse provides oxygen for dyspnea and analgesics for pain and apprehension. Close monitoring of vital signs is necessary, as is observing the client at frequent intervals for changes. The nurse institutes continuous EKG monitoring because right ventricular failure is a common problem. Areas for the nurse to monitor include fluid intake and output, electrolyte determinations, and ABGs. The nurse assesses the client for cyanosis, cough with or without hemoptysis, diaphoresis, and respiratory difficulty. He or she monitors blood coagulation studies, partial thromboplastin time, and prothrombin time when anticoagulant or thrombolytic therapy is used. The nurse assesses the client for evidence of bleeding and relief of associated symptoms. Because clients with pulmonary emboli are discharged on oral anticoagulants, they require instruction related to checking for signs of occult bleeding, taking medication exactly as prescribed, reporting missed or extra doses, and keeping all appointments for follow-up blood tests and office visits. Acute respiratory distress syndrome. Acute respiratory distress syndrome, ARDS, is a clinical condition that occurs following other clinical conditions. The less severe form of this condition is referred to as acute lung injury, ALI. ARDS and ALI are not primary diseases. When it occurs, ARDS can lead to respiratory failure and death. It is referred to as non-cardiogenic pulmonary edema. Pulmonary edema not caused by a cardiac disorder occurs without left-sided heart failure. Sudden and progressive pulmonary edema, increasing bilateral infiltrates seen on chest X-ray, severe hypoxemia, and progressive loss of lung compliance categorizes the ARDS. Factors associated with the development of ARDS include aspiration related to near drowning or vomiting, drug or alcohol ingestion or overdose, hematologic disorders such as disseminated intravascular coagulation or massive transfusions, direct damage to the lungs through prolonged smoke inhalation or other corrosive substances, pneumonia or localized lung infection, metabolic disorders such as pancreatitis or uremia, shock, trauma such as chest contusions, multiple fractures or head injury, any major surgery, embolism, and septicemia. The mortality rate with ARDS is high, particularly if the underlying cause cannot be treated or is inadequately treated. The body responds to the injury by reducing blood flow to the lungs, resulting in platelet clumping. The platelets release substances such as histamine, bradykinin, and serotonin, causing localized inflammation of the alveolar membranes. Increased permeability of the alveolar capillary membrane subsequently ensues. Fluid then enters the alveoli and causes pulmonary edema. The excess fluid in the alveoli and decreased blood flow through the capillaries surrounding them causes many of the alveoli to collapse, called microatelectasis. Gas exchange decreases, resulting in respiratory and metabolic acidosis. ARDS also causes decreased surfactant production, which contributes to alveolar collapse. The lungs become stiff or non-compliant. Decreased functional residual capacity, severe hypoxia, and hypocapnia result. Severe respiratory distress develops within 8 to 48 hours after the onset of illness or injury. In the early stages, few definite symptoms can be seen. As the condition progresses, the following signs appear: increased respiratory rate, which is shallow, labored respirations, cyanosis, use of accessory muscles, respiratory distress unrelieved with oxygen administration, anxiety, restlessness, mental confusion, agitation, and drowsiness with cerebral anoxia. Respiratory failure describes the inability to exchange sufficient amounts of oxygen and CO2 for the body's needs. Even when the body is at rest, basic respiratory needs cannot be met. The ABG values that define respiratory failure include ABG results of a PaO2 less than 50 millimeters mercury, a PaCO2 greater than 50, and a pH less than 7.3. Respiratory failure is classified as acute or chronic. Acute respiratory failure occurs suddenly in a client who previously had normal lung function. In chronic respiratory failure, the loss of lung function is progressive, usually irreversible, and associated with chronic lung disease or other disease. Acute respiratory failure is a life-threatening condition in which alveolar ventilation cannot maintain the body's need for oxygen supply and CO2 removal. The result is a fall in arterial oxygen called hypoxemia and a rise in arterial CO2 called hypercapnia, detected by ABG analysis. Ventilatory failure develops when the alveoli cannot adequately expand, when neurologic control of respirations is impaired, or when traumatic injury to the chest wall occurs. The most common diseases leading to chronic respiratory failure are COPD and neuromuscular disorders. The underlying disease accounts for the pathology that is seen when the respiratory system fails. Gas exchange dysfunction occurs over a long period. Symptoms of acute respiratory failure are not apparent in chronic respiratory failure because the client experiences chronic respiratory acidosis over a long period. Assessment findings: apprehension, restlessness, fatigue, headache, dyspnea, wheezing, cyanosis, and use of the accessory muscles of respiration are seen in clients with impending respiratory failure. If the disorder remains untreated, or if treatment fails to relieve respiratory distress, confusion, sleepiness, loss of consciousness, tachypnea, cyanosis, cardiac dysrhythmias, and tachycardia, hypotension, CHF, respiratory acidosis, and respiratory arrest occur. The client's symptoms or history, such as surgery or a known neurologic disorder, and ABG results form the basis for a diagnosis of respiratory failure. Additional tests include chest X-rays and serum electrolyte determinations. Treatment of respiratory failure focuses on maintaining a patent airway in cases of upper respiratory airway obstruction by inserting an artificial airway such as an endotracheal or a tracheostomy tube. Additional treatments include administration of humidified oxygen by nasal cannula, Venturi mask, or rebreather masks. Respiratory failure is managed with mechanical ventilation using intermittent positive pressure ventilation. When possible, the underlying cause of respiratory failure is treated. Nursing. Because symptoms often occur suddenly, recognition is important. The nurse must notify the physician immediately and obtain emergency resuscitation equipment. Assessment and monitoring of respirations and vital signs are necessary at frequent intervals. The nurse must pay particular attention to respiratory rate and depth, signs of cyanosis, other signs and symptoms of respiratory distress, and the client's response to treatment. The nurse monitors ABG results and pulse oxys findings and implements strategies to prevent respiratory complications such as turning and range of motion exercises. The nurse provides explanations to the client and initiates measures to relieve anxiety. Malignant disorders. Tumors and growths affecting the respiratory system usually are malignant. Malignancies may be primary in that they arise from the lungs or mediastinum, or they can be secondary metastatic growths from other sites. Treatment of primary or secondary cancers usually does not stop progression of the disease. Disability, debilitation, and death are common outcomes from respiratory malignancies. Lung cancer is a very common cancer, particularly among cigarette smokers and those regularly exposed to secondhand smoke. It remains the primary cause of cancer-related deaths among men and women in the U.S., per the American Cancer Society of 2016, with more Americans dying each year from lung cancer than from breast, prostate, and colorectal cancers combined. The incidence of lung cancer has markedly increased since the early 1980s, related to the following: more accurate methods of diagnosis, the growing population of aging people, the continued popularity of cigarette smoking, increased air pollution, and increased exposure to industrial pollutants. The American Cancer Society in 2016 published the following statistics related to lung cancer. Lung cancer, both small and non-small cell, is the second most common cancer in both men and women, not counting skin cancer. Lung cancer accounts for 14% of all new cancer diagnoses. It is predicted that 25% of all cancer deaths in 2016 will be from lung cancer. Lung cancer occurs primarily in older adults, the average age at the time of diagnosis being 70 years. The exact mechanism for the development of lung cancer is unknown. However, the link between irritants and lung cancer is well established. Prolonged exposure to carcinogens more than likely will produce cancerous cells. Smokers who quit reduce their risk of lung cancer to that of non-smokers within 10 to 15 years. Lung cancers are grouped in three overall categories: non-small cell lung carcinomas, which include epidermoid or squamous cell carcinomas, large cell or undifferentiated type, and adenocarcinoma; small cell lung carcinomas, formerly referred to as oat cell carcinomas, and lung carcinoid tumors, also known as neuroendocrine tumors, that are rare. Many tumors begin in the bronchus and spread to the lung tissue, regional lymph nodes, and other sites such as the brain and bone. Many tumors have more than one type of cancer cell, referred to as mixed small cell, large cell cancer. The transformation of an epithelial cell in the airway initiates the growth of a lung cancer lesion. As the tumor grows, it partially obstructs the lumen of an airway or completely obstructs it, resulting in airway collapse distal to the tumor. The tumor may hemorrhage, causing hemoptysis. The cell type of the lung cancer, size and location of the tumor, and degree and location of metastasis determine the presenting signs and symptoms. A cough productive of mucopurulent or blood-streaked sputum is a cardinal sign of lung cancer. The cough may be slight at first and attributed to smoking or other causes. The cough can be new or noticed by a client as different from a chronic cough. As the disease advances, the client may report dyspnea, fatigue, anorexia, and weight loss. Chest pain occurs later in the disease. Hemoptysis is common. Some clients exhibit recurring fevers and frequent respiratory infections before lung cancer is diagnosed. If pleural effusion occurs from tumors spreading to the outside portion of the lungs, the client experiences dyspnea and chest pain. Other indications of tumor spread are symptoms related to pressure on nerves and blood vessels. Symptoms include head and neck edema, pericardial effusion, hoarseness, and vocal cord paralysis. Early diagnosis of cancer of the lung is difficult because symptoms often do not appear until the disease is well established. The sputum is examined for malignant cells. Chest x-rays may or may not show a tumor. A CT or PET scan or MRI is done if results from the chest x-rays are inconclusive or to further delineate the tumor area. Sputum cytology may be done in coughed up sputums specimens. Bronchoscopy may be done to obtain bronchial washings and a tissue sample for biopsy. Fine needle aspiration under fluoroscopy or CT guidance may be done to aspirate cells from a specific area that is not accessible by bronchoscopy. A lung scan may also locate the tumor. A bone scan detects metastasis to the bone. The results of a lymph node biopsy may be positive for malignant changes if the lung tumor has metastasized. Mediastinoscopy provides a direct view of the mediastinal area and possible visualization of tumors that extend into the mediastinal space. The client's prognosis is poor unless the tumor is discovered in its early stages and treatment becomes immediately. Because lung cancer produces few early symptoms, its mortality rate is high. Metastasis to the mediastinal and cervical lymph nodes, liver, brain, spinal cord, bone, and opposite lung is common. Treatment depends on several factors. One major consideration is the classification and staging of the tumor. Staging refers to the extent and location of the tumor and the absence or presence and extent of metastasis. Other factors that determine treatment are the client's age and physical condition and other diseases or disorders such as kidney disease and CHF. Surgical removal of the tumor offers the only possibility of cure and usually is successful only in the early stages of the disease. Lymph nodes may also be excised to check for cancer. Radiation therapy may help to slow the spread of the disease and provide symptomatic relief by reducing tumor size. In turn, pain, cough, dyspnea, and hemoptysis may be relieved. In a small percentage of cases, radiation may be curative, but for most it is palliative. Complications associated with the use of radiation therapy include esophagitis, fibrosis of lung tissue, and pneumonitis. Chemotherapy may be used alone or with radiation to slow tumor growth and reduce tumor size and accompanying pressure on adjacent structures. Chemotherapy is also used to treat metastatic lesions. Most chemotherapeutic regimens use a combination of drugs rather than a single agent, and although not curative, often make the client more comfortable. Trauma. All chest injuries are serious or potentially serious. A client with a chest injury must be observed for dyspnea, cyanosis, chest pain, and weakened rapid pulse and hypotension, all signs and symptoms of respiratory distress. Clients with a chest injury need to be examined by a physician as soon as possible. Fractured ribs are a common injury and may result from a hard fall or blow to the chest. They're usually not considered serious unless accompanied by other injuries. Automobile and household accidents are frequent causes of fractured ribs. Rib fractures are painful but not generally life-threatening. When a client experiences a fractured rib, other structures may be injured as well. The sharp end of the broken rib may tear the lung or thoracic blood vessels. If the injury involves fractured ribs without complications, the client usually may return home after emergency treatment. Flail chest occurs when two or more adjacent ribs fracture in multiple places, two or more, and the fragments are free-floating. This affects the stability of the chest wall and results in impairment of chest wall movement. A paradoxical movement develops. With inspiration, the chest expands, but the free-floating segments move inward instead of outward. On expiration, the free-floating segments move outward, interfering with exhalation. These movements affect intrathoracic pressures, significantly decreasing the movement of air. Many pathophysiological phenomena occur as a result. Increased dead space, reduced gas exchange, decreased lung compliance, retained airway secretions, atelectasis, and hypoxemia. Symptoms consist primarily of obvious trauma and severe pain on inspiration and expiration. With flail chest, the client has hypotension and inadequate tissue perfusion, secondary to decreased cardiac output. Respiratory acidosis occurs because of increased CO2. Chest x-rays, usually from several angles, are necessary to confirm the diagnosis. Medical management is supporting the chest with an elastic bandage or a rib belt, assist in immobilizing the rib fractures. These measures, however, can lead to decreased lung expansion, followed by pulmonary complications such as pneumonia and atelectasis. The use of these devices usually is limited to multiple rib fractures. Analgesics such as codeine may be prescribed for pain. Sometimes a regional nerve block is used to relieve pain. Management of flail chest includes supporting ventilation, clearing lung secretions, and managing pain. Other treatment depends on the severity of the flail chest. If a pulmonary contusion, which is crushing bruise of the lung, also exists, fluids are restricted because of the damage to the pulmonary capillary bed. Antibiotics are given to prevent infection, which is common. Endotracheal intubation and mechanical ventilation may be necessary if a client's respiratory status is greatly compromised. With fractured ribs, the nurse may apply the immobilization device after the doctor examines the client. In such a case, the nurse instructs the client about the application and removal of the rib belt or elastic bandage, stressing the importance of taking deep breaths every 1 to 2 hours, even though breathing is painful. Nurses plan and implement care of clients with more severe injuries based on respiratory needs. The nurse assesses and monitors the client for signs of respiratory distress, infection, and increased pain. Blast injuries. Compression of the chest by an explosion can seriously damage the lungs by rupturing the alveoli. Death often results from hemorrhage and asphyxiation. Severe respiratory distress with outward evidence of chest trauma is apparent. Subcutaneous emphysema, air in subcutaneous tissues, is a common finding because the lungs or air passages have sustained an injury. This condition resembles a superficial swelling. Crepitation, a crackling sound, is heard or felt upon palpation and may be caused by air leaking around the chest wound. Diagnosis is based on symptoms and physical examination. Additional diagnostic tests such as chest x-rays and lung scans may be necessary to identify foreign objects or air in the chest. Treatment includes complete bed rest and oxygen administration. Thoracentesis to remove air or fluid may be necessary. Some clients may require surgery and the insertion of chest tubes if severe injury to lung tissue has occurred or if pneumothorax is present. When a client has suffered a blast injury, the most important nursing task is immediate recognition of respiratory distress. Victims of a blast injury are closely observed for early signs of respiratory distress. Penetrating wounds. Gunshot and stab wounds are common types of penetrating wounds to the lungs. Penetrating wounds potentially affect cardiopulmonary function and may be life-threatening. Penetrating wounds are classified according to the velocity of the cause. Stab wounds from weapons such as knives or switchblades usually are low velocity because they involve a small area. Gunshot wounds may be low, medium, or high velocity depending on the caliber of the gun, the distance from which the gun was fired, and the nature of the ammunition. Any type of penetrating wound to the chest is serious because of the opening into the thorax. On inspiration, the thorax normally is at negative pressure. The penetrating wound creates continuous and direct communication with the outside, which is at positive pressure. Air enters the thoracic cavity, causing an open pneumothorax. If not recognized and treated promptly, death may occur. If the wound is large, a sucking noise may be heard as air enters and leaves the chest cavity. Depending on the size of the wound, it takes seconds to hours before the lung collapses as the pressures in the thorax reach atmospheric pressure. Many chest injuries involve both pneumothorax and hemothorax, the collection of blood in the pleural cavity. Subcutaneous emphysema also may be present. Other possible trauma includes hemorrhage, lung contusion, damage to surrounding tissues, fractured ribs or other bones, and injury to the heart, blood vessels, or both. Clients exhibit various signs and symptoms depending on the location and extent of the penetrating wound. Dyspnea, pain, and bleeding are common. Clients are at risk for respiratory distress and shock. It is also important that the client be thoroughly examined to ascertain if other injuries are present, such as more penetrating wounds, particularly in the abdominal area. Diagnosis is based on the history of injury, physical exam, and auscultation of the lungs. Chest x-rays show the degree of lung collapse and the amount of air or blood in the thoracic cavity. The client's cardiopulmonary status is assessed through ABG analysis, pulse ox, and EKGs. CT scans or MRIs may be necessary depending on the extent of the injuries. Airway management is the first concern. Once an airway is established, then other treatment begins. Thoracentesis is done to remove air and blood from the pleural space. A chest tube is inserted and attached to an underwater seal drainage system. A thoracotomy may be required to repair the injury. Foreign bodies that entered the chest, such as a bullet or a knife, are surgically removed. Their presence in the wound may prevent or slow the entrance of air. Removal before the victim is transported to the hospital may result in continuous sucking of air into the chest, collapse of the lung, compression of the heart, and opposite lung, and death. Surgical intervention may be necessary if there is bleeding from the chest tube or indications of injury to other organs or blood vessels. Emergency treatment of pneumothorax caused by a penetrating wound includes the application of a tight pressure dressing over the injury site to prevent more air from entering the thorax. Immediate evaluation of the client's respiratory status is imperative. Oxygen is given until the physician examines and treats the injury. IV fluids, colloid solutions, or blood is administered to treat or prevent shock. An indwelling catheter is inserted to monitor urine output. A nasogastric tube is placed to prevent aspiration of stomach contents and to decompress the GI tract. Care of a client with a penetrating wound, chest wound, is similar to that of a client who has thoracic surgery. A thoracotomy is a surgical opening in the chest wall. A thoracotomy is a surgical opening in the chest wall. It may be done to remove fluid, blood, or air from the thorax, remove tumors of the lung, bronchus, or chest wall, remove all or a portion of a lung, repair or revise structures contained in the thorax, such as open heart surgery or repair of a thoracic aneurysm, repair trauma to the chest or chest wall, such as penetrating chest wounds or crushing chest injuries, sample a lesion for biopsy, remove foreign objects such as a bullet or metal fragments. A thoracentesis may be done as emergency procedure to remove blood, fluid, or air from the chest. In some cases, it is necessary to perform a thoracotomy to insert chest tubes to remove air or fluid from the chest during the preoperative period. Preparing clients for thoracic surgery includes the assessment of vital signs and breath sounds, particularly noting the presence of or absence of breath sounds in any area of the chest. The client's condition dictates the extent of the assessment in obtaining a history. If the surgery is an emergency, physical assessment may be limited to a general statement of the client's condition, a list of emergency measures and treatments done, and vital signs. Post-op nursing management. The opening of the thoracic cavity requires special post-op nursing measures. A significant issue is the interference with normal pressures in the thoracic cavity. When the chest is opened, air from the atmosphere rushes in, owing to the negative pressure that exists in the thoracic cavity on inspiration. The entrance of air under atmospheric pressure causes the lung to collapse and no longer expands or contracts. The anesthesiologist ventilates the client during surgery. After thoracic surgery, draining secretions, air, and blood from the thoracic cavity is necessary to allow the lungs to expand. A catheter placed in the pleural space provides a drainage route through a closed or underwater sealed drainage system. Sometimes two chest catheters are placed, one anteriorly and one posteriorly. The anterior catheter, usually the upper one, removes air. The posterior catheter removes fluid. Chest tubes are securely connected to an underwater sealed drainage system. The tube coming from the client always must be underwater. A break in the system, such as loose or disconnected fittings, allows air to first enter the tubing and then the pleural space, further collapsing the lung. When chest tubes are inserted at the end of the surgical procedure, they are connected to an underwater sealed drainage system. All connections are taped carefully to minimize the possibility of air entering the closed system. When caring for a client with chest tubes, the nurse should be aware of the following. Fluctuation of the fluid in the water-sealed chamber is initially present with each respiration. Fluctuations cease when the lung re-expands. The time for lung re-expansion varies. Fluctuations also may cease if the chest tube is clogged, the wall suction unit malfunctions, a kink or dependent loop develops in the tubing. Bubbling in the water-sealed chamber occurs in the early post-op period. If bubbling is excessive, the nurse checks the system for leaks. If leaks are not apparent, the nurse notifies the physician. Bloody drainage is normal, but drainage should not be bright red or copious. The drainage tubes must remain patent to allow fluids to escape from the pleural space. Clogging of the catheter with clots or kinking causes drainage to stop. The lung cannot expand, and the heart and great vessels may shift, called a mediastinal shift, to the opposite side. The nurse must be alert to the proper functioning of the drainage system. Malfunctions need immediate correction. If a break or major leak occurs in the system, the nurse clamps the chest tube immediately with hemostats kept at the bedside. He or she notifies the physician if this occurs. Immediate post-op care includes following the standards outlined in Chapter 14. It is also essential that the nurse check the underwater seal drainage system, noting the amount and color of drainage and any bubbling or fluctuation. The nurse assesses dressings for drainage and firm adherence to the skin, inspecting the skin around the dressings for signs of subcutaneous emphysema. The nurse assesses the client's color, neurostatus, and heart rate and rhythm, monitors respiratory rate, depth, and rhythm, and auscultates the chest for normal and abnormal breath sounds. He or she also assesses levels of pain and anxiety. The client's left thoracotomy tube is connected to water seal drainage and suction. The client is to be transported to the X-ray department. How will the nurse transport the client? Will she disconnect the suction and maintain the water seal drainage system? Ask if the X-ray department can possibly do its procedure in the client's room? Disconnect the chest tube from the water seal drainage system? Obtain a portable suction machine from Central Supply to transport the client. The answer is A, disconnect the suction and maintain the water seal drainage system. The rationale is this is the only choice that maintains the water seal drainage. The client cannot be off suction for short periods. Can only be off suction for short periods. This is the end of the slideshow.